Good evening. My name is Jay Feinberg, and I'm Gift of Life's founder and CEO. It is my great pleasure to welcome you to Gift of Life's Georgia Town Hall, addressing healthcare disparities in our communities. I'd like to thank our organizing partner, the NAACP, and our sponsors, Morgan Stanley, Fidelity Investments, the McKesson Foundation, and Rubius Therapeutics for their tremendous support. Today's topic could not be more timely or important. We have watched as COVID-19 has spread throughout the United States, leaving a trail of destruction in its wake. And we have been reminded of the inequities that permeate healthcare, resulting in unequal outcomes for people of color. These disparities extend far beyond our mission to provide a cure for those battling diseases like blood cancer, immunodeficiencies, and sickle cell. But as part of our mission to create equal healthcare outcomes for everyone, we are compelled to take action addressing not only this, but the larger issue that the pandemic has further exposed. My personal story began in the early 1990s when I was diagnosed with leukemia. Naturally, I was devastated, but relieved to learn that a bone marrow transplant could save my life. First, though, I would need to find a matching bone marrow donor. It wasn't until I met with a transplant physician in New York that I was told that I would never find a match because of my Jewish genetic heritage. I had no idea that tissue type is inherited, like the color of our eyes or our hair. So the best chance of finding a genetic match lies with people of similar race and ethnicity. Unfortunately, the donor registry was not ethnically and racially diverse, likening the search to looking for a needle in a haystack. Thankfully, with a lot of hard work and a 4-year high-profile grassroots campaign, I found my match. Now it's my life's mission to pay it forward. Every patient deserves an equal opportunity to benefit from the treatment that can save their life. The registry must be representative of people of all backgrounds. To help give voice to this message and encourage others to join in the fight against blood diseases, Gift of Life has launched a new short film in collaboration with rapper and lyricist Terrell Trizzy Miles, with creative support from the Lucy Collective and The Mill. Allow me now to please introduce Blood is Thicker Than Water.
So Terrell, what made you want to write this book?
Because blood is thicker than water, like fathers,
mothers, sons, and daughters. But what if I told you the blood relation can go farther than the people you know? You have the power to save a life with a simple swab of the cheek. That's all you need to make someone else's life complete. For those like me or from a different creed, no matter what you look like, there's someone out there who you can be. A hero to, a vessel of new life. Someone who can bring them light when the road seems weak. For those who seek bone marrow or stem cells, through this one gesture, they will be allowed to prevail and tell the tale of how one small act managed to break the scale, and their life was allowed to once again set sail to heights unknown, to love once more. The gift of life, from my family to yours.
Absolutely incredible. Terrell, if you're listening, you are just so incredibly talented, and thank you for doing this. The film you just saw, Blood is Thicker, is one of the initiatives we've put in place to educate communities on these very important issues. This town hall is another. And so in partnership with the NAACP and Dynamic Changemakers, we are pleased to have you join us for this one of many meaningful conversations about ensuring that Black, Indigenous, and people of color have safe, effective, and full access to healthcare and life-saving treatments. Now, it is my great pleasure to welcome tonight's moderator, 11 Alive news anchor, Ron Jones.
All right, thanks a lot, Jay. I really appreciate that. Good evening, everyone. Glad to see that you're here. I'm Ron Jones, as Jay just pointed out. And on behalf of Gift of Life Marrow Registry, we are really excited to discuss the pressing issues surrounding health disparities and how we can all of us can play a role in the solutions to affect lasting impact. The coronavirus pandemic and the recent racial turmoil have brought racial healthcare inequality to the forefront of the national headlines and even locally as well, and to everyone's awareness on social media, as I'm sure you're aware of. The U.S. accounts for more than 8 million COVID-19 cases, and the death toll from the coronavirus has now topped 226,000 people, more than 250,000 people. Black, Latino, and Indigenous people of all across the country and every age group, including young people, have been disproportionately affected by the coronavirus. They are more likely, get this, they're more likely to be diagnosed with the virus, more likely to suffer serious illness, more likely to be hospitalized because of the virus, and more likely to die from it. The numbers and data points highlight the underlying and long-standing healthcare inequities that have existed in our country, especially in Black and other communities of color. And these health disparities have been fueled by decades of discrimination, mistrust of the healthcare system, unequal treatment, unequal opportunities for economic, physical, and emotional health, and other issues that limit access to quality care. So as a result, the health and wellness of people in minority communities is often shaped by a deadly cycle of chronic disease and, unfortunately, loss of life. A cycle that continues through generations. It's a cycle that devastates families and communities as well. And these challenges remind all of us that the barriers to healthcare are interconnected. They're interconnected, and the problem is bigger than any one disease or chronic health condition. But here's the biggest challenge for all of us, folks. Many people believe that they cannot take action because the solutions often overwhelm instead of inspire us. As you've already heard from Jay, he told us his story. Changing health outcomes is possible. It can happen. Through action, Jay was able to turn a moment of crisis into one of transformation. And you're going to hear from more people shortly who agree and are working to overcome those healthcare disparities. And we're going to explore how advocacy, partnerships, and youth-led efforts can serve as a powerful catalyst toward building and sustaining healthy and equitable communities through the discussion with our esteemed panelists, Dr. Brian Rivers, renowned cancer researcher and Morehouse School of Medicine faculty and a steering committee member of the American Association for Cancer Research Cancer Health Disparities Progress Report, and Dr. Kimberly Carr. She's a community resource specialist with Georgia Rural Health Innovation Center, and Dr. Jonathan Shepard, a physician and a board-certified child, adolescent, and adult psychiatrist who also serves as the president of the board for the Black Mental Health Alliance. So lastly, we're going to speak with Amari Fanoy, who is, as a certified civic engagement trainer with the NAACP, is now working with the youth and college division of the NAACP all across our great country in support of this program. And not only are our youth providing a catalyst and prolific communicators in social movements, but we believe their involvement is key, is crucial in creating healthier communities. So we want to invite all of you out there who are watching, listening, to submit your questions in the chat for a brief Q&A with our experts at the end of this program. But first, why don't we kick things off? Let's welcome Dr. Brian Rivers, Dr. Kimberly Carr, Dr. Jonathan Shepard. Welcome, everyone. I really appreciate you, all of you being here. We're going to begin with Dr. Brian Rivers. So from your perspective, sir, how has the COVID-19 pandemic served as a tipping point for disparities in communities of color? And what are the lessons we can learn from this pandemic?
Sure. Well, thank you, Ron. Definitely is a pleasure to be here this evening having this conversation. So health disparities isn't something new. It's something that we are very familiar with and that we have been studying at least for the past 50 years. And so we've done a great job, I think, in describing health disparities and understanding some of the causal mechanisms associated with health disparities. But now we have much work to do in terms of how do we actually intervene on some of these health disparities. Now, we know in this country that racial and ethnic minority populations are among the U.S. population groups that have long experienced cancer health disparities and also health disparities in general. Many of these U.S. populations that experience these disparities, we have found in recent months, especially among African Americans and Hispanics, are also experiencing disparities in the context of this, where we find ourselves in this pandemic called COVID-19. Certain factors that have been attributed to why this disparity exists in COVID-19 has been partially explained as an amplification of disparities that existed prior to the pandemic we find ourselves in. And we know that these factors are complex in scope, as you mentioned in your opening comments. They're also interrelated in some regards. For example, we know that racial and ethnic minorities are more likely to have one or more health conditions that increases one's risk of the severity of COVID disease if they should contract it. We also know that social determinants play a key role in the disparities that we see in the context of COVID-19. And what are social determinants? Well, defined by the National Institutes of Health and the National Cancer Institute, social determinants are those conditions in which people are born, they work, they grow, they live, they thrive. These are emerging as some of the most important factors contributing to the racial and ethnic COVID-19 disparities we are witnessing and have witnessed over the last 6 months. Other factors that may contribute to this disproportionate outcome or impact includes racial and minority groups are more likely to live in conditions that pose challenges for social distancing. So living in populated or densely populated neighborhoods or communities. We realize and we have found through research that this is one of the main strategies for reducing infection with SARS COVID-19 or COVID-2. For example, we find that individuals who are residing in these densely populated neighborhoods are more likely to live in lower income apartment complexes with higher numbers of occupants per unit, and are more likely to live in multi-generational family units that, of course, places everyone at increased risk for COVID-19. We also know that there are some racial and ethnic minority groups that are more likely to work in occupations that are considered essential for society to function. You may have heard the term called essential workers. Well, these are individuals that are operating in grocery stores or hospitals or nursing homes, who are those that are on the front line of exposure. And so that increases the likelihood that they're adversely impacted or diagnosed with COVID and then adversely impacted with the subsequent sequelae of events that happen as a result of diagnosis. Also, those who work in building maintenance or public transportation or even delivery services are all, again, these essential workers that are at increased exposure for COVID-19. And all of these factors, again, increases the chances of developing and then suffering from COVID-19. We also know that racial and ethnic minority groups are more likely to have jobs that may not provide a secure income, okay? Only paying if the individual shows up to work, which means that they are more likely to leave their home, increasing the chance of exposure to SARS-CoV-2. So another important factor contributing to racial and ethnic COVID-19 disparities is that many people in racial and ethnic minority groups are more likely to have one or more of the health conditions that we have found through research to increase a person's chance of severe COVID-19 when compared to non-Hispanic whites. Some of these conditions include chronic kidney disease, chronic obstructive pulmonary disease, or commonly referred to as COPD, obesity, heart failure, coronary artery disease, sickle cell disease, diabetes, and then overall just having a weakened immune system for a variety of reasons. We know that all of these are factors that have been shown to increase one's risk of contracting COVID-19. And other conditions that we're seeing associated include asthma as well as high blood pressure. And lastly, I want to touch on one last factor, and we've heard about it, and I think it has really been highly politicized in this recent election we find ourselves in, but the inequities of access to care. We see that it remains an issue for racial and ethnic minority groups here in this country. And so having adequate access to care or inadequate access to care can hamper one's ability to be screened in a timely manner, to receive those screening results in a timely manner, and then intervene accordingly should it necessitate some level of intervention based on the screening results. So all of these factors or actions are constrained with the lack of access to healthcare. Now,
Yeah.
early in the pandemic, we found that many of the testing centers where individuals can go and be screened were located in neighborhoods that historically had not suffered from disparities. And so we found those who historically have suffered from disparities had a difficult time accessing those screening sites. And so changes have been made as our understanding increased of the need to place these screening sites in neighborhoods that are historically have been disproportionately impacted by chronic conditions and infectious conditions as well, and place them where they're more accessible. So those type of structural changes and that type of thinking, I think is part of the solution going forward. In addition, there appears to be deep concern that undocumented immigrants will experience adverse differences in COVID-19 measures, in large part because of a lack of access to quality health care. And so some of the lessons I think that we've learned thus far, and this is the dynamic situation that we find ourselves in, and so the lessons are continuously being learned, is that one, this is a complex problem as relates to understanding how to prevent one from COVID-19. But then also we're seeing a lot of parallels as relates to health disparities in general in other indications or other disease sites, such as cancer, such as heart disease, such as diabetes and asthma. And we realize that in order to adequately address this issue, that it's multifactorial in scope, that there's multiple factors and components that matter, that really are associated with these adverse outcomes. And so what are some of these? Well, social factors, for example. We realize that education and income is are key social factors, that are associated with one's risk and exposure rate to COVID-19. Clinical factors such as access to healthcare, behavioral factors such as tobacco use, obesity, and physical inactivity, and cultural factors such as one's cultural health beliefs and their cultural seeking behaviors are all factors that are of immense importance if we want to get rid of the disparity that we're seeing in COVID-19, but then across all different disease types. Additional factors include psychological factors such as stress and mental health. I mean, there's some fascinating research that is emerging, really showing how chronic stress and the physiological response that chronic stress can have on an individual and how it can impact their health outcomes. And this chronic stress may be individually mediated or it could originate outside of the individual, whether at the neighborhood level or the societal level. But this chronic stress that may come in the form of bias or discrimination or racism, and understanding that chronic exposure of stress over the long term and how it is associated with adverse health outcomes. There's some fascinating research coming out, especially in the context of cancer disparities. And then lastly, I just want to mention environmental factors such as housing and transportation, and biological and as well as genetic factors. And so it's clear that we need in this country to increase our investment as it relates to really eliminating health disparities in this country. We realizing that there are some groups that are disproportionately impacted by every disease. And that's the constant. And that's the question that baffles me, baffles a lot of my colleagues. Like, what are these racial and ethnic minority groups doing so differently in society? How are they interacting so differently to produce such disproportionate health outcomes?
Yeah, those are really good points there, Dr.
Okay.
Rivers. And and I just want to say this. I have another question for you, one last question for you before we go to our other panelists, Dr. Rivers. Jay has already mentioned the disparity in the ability for Black people to find bone marrow or stem cell match. So the AACR Cancer Progress Report 2020, it also reveals that the burden of cancer disproportionately impacts racial and ethnic minorities. So can you shed some more light on this? Why are we seeing this?
Yeah, and it really goes in step with, you know, everything that I just mentioned. A lot of those factors, you know, are parallel across different disease types. So, you know, I had the honor and privilege of serving on the inaugural ACR Cancer Disparities Progress Report that was actually initially introduced in Congress last month, and it's a tool that helps us better understand some of the causal factors related to, you know, the disproportionate impact that of cancer that we see, again, among racial and ethnic minority populations in this country. For example, Black men are more likely to not only be diagnosed with prostate cancer, but then die from prostate cancer. Breast cancer, for example, although white women are more likely to be diagnosed with breast cancer, Black women are more likely to die from breast cancer. So, you know, what is going on? And, you know, and so again, we know that it's multiple factors, multiple components, you know, to this situation, to this circumstance, to these events that, you know, this report allows us to better understand. So it really showed us for the first time the advances that we've made as it relates to addressing cancer health disparities. And then it also puts forth solutions or potential interventions that can help us mitigate some of the disparities that we're seeing, whether it's at the biological or genetic level, whether it's at the social level, whether it's at the psychological level, or even the behavioral level. You know, in the report, it dictates that almost 40% of cancers could be prevented through modifiable risk factors, whether that's tobacco usage, whether that's physical activity or inactivity, whether that's nutrition, and then lastly, whether it's UV exposure, knowing that 40% of cancers could be prevented if we just intervene on those different variables. And so it's a great report. It's a tool that should be used for advocacy, should be used by all aspects of government, because it really provides a comprehensive picture in terms of where we are in this country as it relates to addressing cancer health disparities and what work remains to be done. We have some outstanding testimonies from cancer survivors that really share their story, you know, how they fought through their diagnosis, fought through the treatment, and decided on the other side to come back and make a difference. And so it's an exciting tool, and I strongly encourage, you know, your audience, the listening audience, to, you know, definitely access it and learn more about it.
Okay, Dr. Rivers, we really appreciate that. Why don't we bring in Dr. Kimberly Carr? So Dr. Carr is a third-generation descendant of one of the men unethically and immorally treated in the infamous Tuskegee syphilis study. Your family knows firsthand about medical mistrust. Can you briefly recount what happened and what the ramifications were?
Yes, thank you. I'm so excited to be on the panel. I will try to briefly put together over 40 years of egregious unethical acts committed by the United States government. So the politically correct title we use is the United States Public Health Service Syphilis Study at Tuskegee, to put back the power to the entity that conceived, designed, funded, implemented, and then sustained the study for 40 years. So giving back that ownership to the United States Public Health Service Syphilis Study, instead of calling it the Tuskegee Syphilis Study, because that implies that Tuskegee, the victimized men, conducted the study. So the United States Public Health Service Syphilis Study is the nation's longest non-therapeutic study, and I say so-called study because it would imply that there was written protocol, there was informed consent, and all those things, and it wasn't. It is the longest study in the United States, spanning over 40 years in Macon County, Alabama, Tuskegee, and surrounding areas, where over 600 men were victimized and then coerced, and under the auspices of free healthcare as long as they stayed in the study. The study was wide known. Everyone in the public health field knew about it. There were multiple articles published on it, so it was not one of those unkept secrets. It wasn't until 1972 where Jean Heller, she was an associated reporter, published on the front page news of the New York Times, breaking the story, right? So prior to that, there was a CDC whistleblower, Peter Buxton, who unsuccessfully tried to alert the appropriate entities for the study to stop, but he did what was best, went to the public, and there was a public outcry of that. So after that 1972 public outcry, the surviving men, I believe there was less than 10 at that time, sued the United States government under the services rendered by attorney Fred Gray, civil rights attorney Fred Gray, and I believe he's still practicing now in Tuskegee. He's an awesome tool of education. So that's a little bit about the study itself. A very nice snapshot because I can go on and on, but ramifications, the implications of the study. It wasn't until May 16th, 1997, that President William Bill Clinton in the East Wing of the White House decided to finally apologize for the wrongdoing that the government did to those men, to the Black population of those men. And it was the first time a sitting president ever apologized to a Black population for anything. So that was absolutely wonderful. So the surviving men and their families were there. My great-great-grandfather was not. He had passed long ago, and my grandmother took care of him. She was the oldest of 10, so I'll give a little bit more information about that. And I also want to plug in another ramification is that each year annually, the National Center for Bioethics and Research in Healthcare, which was established as in 1999 as an implication of the study from President Bill Clinton, was established to help dispel that negative legacy of the United States. And it's the first and only presidentially mandated bioethics center in the United States. So to help with this commemoration of the apology in 1997, annually, there are different events held. This year it is held November 9th through the 13th virtually. And the events include the public health ethics intensive course, where different researchers nationally, internationally come in and discuss public health ethics, discuss the study in the context of whatever the theme of the year is. And this year's theme is, I don't want to get it wrong, ethics and vulnerability, the Constitution. So again, that is November 9th through the 13th. There's also a descendants healing session as well. A lot of descendant family members are still hurt from the study. The study was systemic. It wasn't just the men, it was also the wives, it was also the children, it was also future generations, coming down to my generation, standing for you here today in this duality of experience as a descendant family member, as a scholar, and now as a resource specialist in South Georgia. Another ramification of that is the establishment of Voices for Our Founders, Voices for Our Fathers Legacy Foundation. And that is a descendant foundation that is to preserve the legacy of the 623 men that were victimized in the study and to foster social justice, education, and public health research as well. At some point, I can give the link for Voices for Our Father. It's a wonderful organization to be a part of, to have the opportunity to talk about the foundation and to help dispel those negative legacies. The negative legacy that I'm quite sure many people have heard regarding the United States Public Health Service syphilis study, and going forward, I would call it the syphilis study for short, is that there is a reluctance of Blacks to participate in clinical trials. And I get very antsy when I hear that, because there are over 400 years of egregious things and inequities that have happened in the Black population. And it's really unfair, and it's an undue service to say that the United States Public Health Service syphilis study is the turning point as to why Blacks do not participate, which is not true. There are other things like Marion J. Sims, the father of gynecology, who experimented on, African-American slave women. So that's my plug into that. And not only that, these men that we always talk about the study, they were fathers, they were uncles, they were brothers, they were cousins, they were some something that we held and we still hold very, very true to our hearts.
Yeah.
So Katz et al. And a lot of articles now have showed that Blacks are just as willing to participate, but they're just as skeptical. So it's not due to this study, but it could be, not could be, it's the collective trauma of all the years. It wasn't until 1972 when it was publicized because of media, right? The strongholds of media, and then having a sitting president to finally apologize for only one event that has happened to a course of people that were brought over into the 1500s. Like I said, if you want to count Spain as a part of America, well, I won't say America, but the United States before it was formed, but we can discuss that later. Lastly, another ramification is that I want to dispel a lot of myths. One, the men were not injected with syphilis. That is incorrect. If you think about the actual title of the study, it says Tuskegee Study of Untreated Syphilis in the Negro Male in Macon County. It tells you the intent of the story. The government is very intentional about what was to occur. They were interested in the natural progression of syphilis in the male body. The men were worth more dead than they were alive. So they were not injected at all with syphilis. They were also not given treatment. So another thing that is out is this fictitious account with Miss Evers' boys. So that's my, hopefully, children in the background. So that's hopefully okay. I can turn this on because I can hear. So Miss Evers' boys, which is a fictitious account of the United States Public Health Service syphilis study. One, romanticizing it, saying that the men were given treatment, which they were not, which is another unethical feat because penicillin became available and the men still could not get treated. Even going to another county, they could not, they were turned away. And lastly, for this, actually two more things. It is not the Tuskegee experiment. I cringe when I see that. I cringe when I see Tuskegee experiment. Like an experiment would imply that there was scientific rigor, that there was a written protocol, that there was informed consent, there was a checklist. The scientists, the public health service researchers did not keep an accurate account at all. They didn't know who had syphilis. As long as you had syphilis, they didn't care. They did not keep an accurate record. And now the thing is, where are these records? Now the government took samples. Now another dilemma now is, where are these samples? Where are they? They are there somewhere. And now it's, oh, we lost them. The government doesn't lose too much of anything. So again, it's not the Tuskegee experiment. The Tuskegee experiment refers to the Tuskegee Airmen that were in World War II. Tuskegee experiment does an injustice to the descendant family members who are still alive, right? And still giving the legacies of their great-great-grandfathers like myself in front of you, right? Through all these generations, and as well as cousins and uncles and everyone else. And lastly, the notion that all the men were poor, illiterate sharecroppers is incorrect, 100%. And I'll talk a little bit more about the background of my great-great-grandfather and his social determinant of health. And I'm so glad that Dr. Rivers hint on that a little bit, but it has everything to do, health disparities, health inequities have everything to do with wealth, power, and prestige. And you can easily operationalize that to education, income, and occupational status. So those are some of the ramifications of the study. And yeah, that's it.
Okay, well, you know what? You framed that beautifully. I mean, you really did frame that beautifully and gave it so much context for us. So this leads to the next question. I mean, for you and what you do, Dr. Carr, as a community resource specialist, you're working to change those health care disparities in underserved communities in Georgia. So with the mistrust that a lot of African Americans are feeling right now, how can we engage communities to rebuild the trust, especially when we're talking about the coronavirus and a possible vaccine within months?
So that's a great question. And we have all the strategies. I'm quite sure a lot of us went to forums, workshops, use the SMART objective methods, all of those tangible things, but it starts with healing. You're still dealing with the population where the government haven't even apologized for the racialized exploitative agricultural system in which many whites have profited and benefited from through land dispossession, through through different grant funding mechanisms. But that's a whole nother thing that we can talk about. But trust is one of those precious and valuable virtues with engaging communities in general, especially rural communities. And I'm glad that I'm on this panel because oftentimes rural communities are often, left behind. Rural communities are not a monolith, just like the Black population is not a monolith. The rural community, even though it's very vast in nature, it has its own social fabric, its own social cohesion, and its own cultural elements. And when something is broken, it's hard to fix. Just like if you were to break a mirror, you could put it back together, but you still see the cracks. So relative to my family's experience with dealing with trust, and I'm going to say other descendant family members dealing with this mistrust just in general, my great-great-grandfather, due to the perceived social determinants of health, right? Race, they were Black. Income, they didn't have any because they were poor, illiterate, they were sharecroppers. So all of those negative connotations. Now, it was that Macon County had a high syphilis rate, so it could be justified by data, right? But in the early part of the study, the public health researchers already had collected what they needed, but they saw it that this is a peculiar observation that they could look for. It was just like a nice microcosm of looking at this study in the natural progression, because who are going to judge? To stop them? You have powerless people. Yeah. So with that. My great-great-grandfather was not powerless at all. He was a biracial man. He came from a Black mother and a white father. And his white father had given him land. Land is power, land is wealth. But again, that's a whole nother conversation for food sovereignty and equity. Yeah. He owned a farm. He was a clergyman. He had pigs, cows, horses. And then back in those days, that's a Tesla, a Maserati, and a Bugatti. So he had money, he had wealth. So this running narrative that they were poor, illiterate sharecroppers is not a narrative. It's an incorrect narrative. It's a wrong narrative of that ethical, moral imperative. And not only that, it takes away that power, right? And now it focuses in on a powerless monolith of a group of people, which is incorrect. And to elaborate even more, it is very important, again, for researchers, news anchors, academicians, students, to understand our own implicit biases when we're looking at these social determinants of health, especially when we're looking into our rural communities, because they're often the group that is left behind. So at the Georgia Rural Health Innovation Center at Mercer University School of Medicine in Macon, Georgia, we're helping to change that narrative, and we value the diversity that these rural communities have, right? So we try not to focus it on the deficit. Oh, they don't have this, that, and all of those things. They don't have a Walmart. They don't have all right. of these things. We look at it from an asset perspective. We look at it via accessibility, availability, and we look at it for acceptability. What are we? Is it there? Can they access to, and do they accept, the resources that we could potentially provide for them? In doing so, one thing that has, and it's continuing to happen across the board in rural communities, especially in Georgia, a rural hospital in Randolph County closed down. It is in Cuthbert, Georgia. So Randolph County, and like many of the southern counties, well, actually, really, Georgia is considered a Black Belt state, one of 11, if I'm not mistaken. And the 11 Black Belt states really were your slave-holding Confederate states. So that's a whole nother conversation. We're just going to put a pin in. I'm just going to try to wrap this up. But Randolph County, like many of the counties in Georgia, there are approximately 159 counties in Georgia. 120 of them are rural. And most of those rural counties have a very large African-American population. For example, the hospital that closed in Randolph County, Cuthbert, Georgia, have over a 60% African-American population. So it's like, what now? What do we do when we have these rural hospitals closed, when you're already dealing with social isolation, where you're also dealing with transportation barriers, when you're also dealing with transfer? You may have to go to Valdosta, you may have to go to Albany, Georgia, Phoebe Putnam to get the services that you need. So the Georgia Rural Health Innovation Center, we have a data hub with over 250 indicators to where we can monitor and surveil the things that are going on in rural Georgia. One of the things that we are doing to help bridge the gap is partnering with different organizations, and that is one of my roles in doing so. But wrap it up. Telehealth is very important. It's really great. However, rural broadband accessibility is terrible in the rural communities, and we're trying our best our way to facilitate infrastructure in that regard. So
yeah, I can see how infrastructure could be a challenge, especially in those rural areas. So thank you. Why don't we bring in Dr. Jonathan Shepard? And Dr. Shepard, much like the cancer and the coronavirus, Black people are disproportionately weighed down by the heavy burdens of stress. Dr. Rivers talked about that. So COVID-19 is not only causing higher death tolls among Black and brown people, but it is heavily impacting our emotional well-being. So how can people be encouraged to seek mental health help? How do we do that?
Well, first of all, I just want to say thank you all, and thank you, Ron, and thank you for this distinguished panel. You have heard just some tremendous stories thus far. And just listening to these stories, they could potentially weigh you down. We are in the midst of a dual pandemic. Do not be deceived by that. Just because the COVID-19 pandemic has stricken so many people physically, it has done more damage mentally and emotionally. I can prove it. There are just so many different things that have occurred, especially within the Black community. We are living in what I call the quadruple jeopardy year. And really, if you want to say it's probably 5, but I can definitely name 4. The COVID-19 pandemic. Number 2, the healthcare disparities, which has already been talked about. Number 3, the police brutality due to institutional and systemic racism. And then number 4, the financial and economic loss due to the pandemic. Now, so many of these things were already in existence. And so how do we encourage the people to seek help? We have forums like this. We have platforms that exist just like this that encourage the people to let them know that what they are feeling is okay. What do you mean by that, Dr. Shepard? If you're feeling anxious, if you're feeling even down, even a little bit sad, or even want to use the word depressed, it is okay, because what we're experiencing right now, we've never experienced before. And there are a lot of people who are walking around and who are functioning who are not okay. And that is when you know that it is time to seek out for help. So how do we encourage you? We let you know that it is normal to seek out help. When you are discouraged, when you know that you're not functioning properly, there is a little diagram that I would show of the difference between distress and disorder. Everyone is distressed. Everyone is distressed. If you never have distress in your life, then you're not a normal human being. Everyone will experience distress. But what happens is, on the journey of life, as we experience the distress, and this year of 2020 has been an astronomical distressful year, you can become disordered. And when you become disordered, as you go along this continuum, you find yourself not functioning properly. And so for everyone who is out there and you know who you are, I encourage you, it's okay. If you know that you're not functioning properly, it's okay. I want to just help normalize it for you, take the weight off. I am a psychiatrist, busy psychiatrist. I have been seeing so many different patients, but one of the things that I do with my patients, I let them know it's okay to not be okay. And so we in the Black community have to let our guards down. We've been carrying all the weight, and Dr. Carr has just so eloquently testified, if I've used that word, about the different weights that we have carried as a people. And it is time now to let go of some of those weights and to get the help. So I encourage you. Also, I will say this for encouragement. Ask the people in your neighborhood, ask the people in your circle of influence, who they go to when they are in need of mental relief or when they're in need of counseling. I guarantee you there's somebody in your circle who is seeking out help. And so I would say that you can start there, and and hopefully you'll be able to get those persons on your team to help you get the support that you need.
Okay, Dr. Shepherd, obviously you're a professional, so you know exactly how to identify someone who is in need. But what about those of us who are around family and friends? You get busy at work, you're doing this, you're doing that, and you're not quite sure if your coworker or a family member is going through something, but you feel that they are. So how can someone help a friend or other loved one who might need mental health support? What could I do to help out?
Absolutely. There's signs that go around. If you see something, say something. We can recognize when one of us is out of order. And so when someone is not functioning properly, that's when we need to say something. It's not the time to be scared. It's not the time to be frightful, not the time to be timid. We are hurting as a people. We are hurting as a country. We have taken blow after blow after blow after blow, and we still got 2 more months. And who knows what else these two more months may entail for us. The COVID-19 pandemic has been just like a person will come off and rip a Band-Aid off of all the different ills that have been present. These are not new ills. But they have been here just stirring up, and the pandemic has just stirred up the pot, if I can use that as an analogy. And so what we have to recognize is that when we see our people not functioning, we have to say something. When you see that child who's no longer bathing himself or herself, when you see that adult who no longer cares to comb her hair or comb his hair, when you recognize that they're no longer caring for their children, when you recognize that they are no longer eating and sleeping all day, these are different signs and symptoms that we must get up and say something about it. And in my conclusion, because I know we're running out of time here, is that I want to emphasize what mental health is. And this is the standard bearer. There are 4 points to mental health. It's very quick, and it is my mantra. It is PCWC. And so you need to check your PCWC. That is how you can establish if you're functioning properly. Number 1, you recognize your potential. Your potential is your untapped skills and your ability and talents. Anyone who is mentally well will understand his or her potential. Then number 2, cope. When you know that you are mentally well, you know that you can cope with any stressors that may come your way. Like I already said, you will be distressed, but you have to have that ability to cope. The third point, W, work. Any person who is mentally well is able to work effectively and fruitfully. They're not just working to earn a paycheck, but they're working productively, fruitfully, and effectively. And then another thing, the last letter, the last C, is contribution. When you know that you are mentally well, you can know that you can make a positive contribution to your community. And so that's what we have to do. When we recognize that one of those 4 things are out of place, it may be time to seek help. And we do this with sensitivity. No one wants you to come up to them and say, "Oh, girl," or "Man, you crazy." That's not how you approach somebody when you recognize that something is off. We have to have sensitivity. We have to do it with love and with care. And so those are some of the things that I would say how to be able to approach someone when they are not functioning properly.
Man, Dr. Shepherd, thank you. See something, say something. That's exactly right what we should do. Hey, last but certainly not least, we like to welcome Amare Fanoy. And welcome. Thank you for being here with us today. And today's conversation is part of a series of town hall conversations taking place virtually on college campuses and nationwide. So from the NAACP's perspective, what can young people, particularly college students, those who are watching right now, what can they do to make a difference?
Well, thank you for having me, of course. And one thing I want to put forth is as of right now, the youth are basically dominating the programs within NAACP. We are creating them, we are training them, we are pushing forth. The youth in college is a force and has always been a force when it comes to leadership, as well as creating programs that are beneficial to our community. So one thing I would say is actually get involved. And when I say get involved, I don't mean just become a member of these organizations such as NAACP or even the Gift of Life, but be an active member and be an advocate within those, and actually get those trainings and actually educate other individuals within our community who don't have access to those trainings. The Youth in College is built on that foundation of these pillars, and one of those being health, where the We Are Done Dying campaign completely shifted from just explaining what COVID was, but just overarching the pre-existing conditions that we have currently going on, especially one of those pandemics being racism. What we have done is built these programs to educate and promote and have youth understand that our power comes more than just from voting. Yes, get out and vote. Yes, because our lives depend on it, but also create these initiatives so we can continue to spread information such as this panel. We don't know how many people will see this. We don't know how many times this will educate someone or how much new information will be presented. I know we've had a history lesson today from Dr. Carr, as well as we brought up mental health. Was okay to go to a therapist. It's actually promoted to go to a therapist. We've heard about Ms. Henrietta Lacks, and just having those history lessons helps us explain, how we need to continue to build forth and build those gaps that are present when it comes to the mistrust our community has in not just healthcare, but also just as a whole when it comes to politics or healthcare or voting. Building that distrust, building that bridge of distrust by being those advocates, by being those researchers, and actually getting active within these movements.
Yeah, that's really promising. And as we always talk about this, that the youth are our future. And so they have to take the baton and continue on with that process. And so we really appreciate, Amari, you giving us that perspective, and hopefully those young people out there, and I know that they are, that they're fired up and they're going to take that torch and they are going to move forward. Now, I believe at this time, speaking with our producers, we're going to go to the chat room where some folks have some questions out there. And so Jay, here's a question for you. Can you share with everyone what the process is to join the registry? How does that work?
Yeah, so it's actually very simple. Before I describe that, I just want to share something that came to mind throughout. That actually was shared with us by Walter Bond, who is a former NBA player who was with us the other night on one of the town halls. And his advice was never be a spectator, always be a participant, have the right mindset, and be an impact player. And I'm just reminded of that tonight, and particularly when I just heard Amari. It's great to hear that young people on our college campuses are doing just that. Now, as far as joining the registry, very, very simple. It's just a cheek swab, right? Just like this, you swab the inside of your cheek. You order these kits on our website. Typically, we run about 3,000 donor drives every year across the nation. But because of COVID, we're not doing that. We're running all of those drives virtually online. So go to giftoflife.org. You get one of these cheek swab kits. You do your swab at home in your living room, send it back to the lab, and you enter the registry and have the opportunity to save a life one day. One thing that I do want to add is that it's important for people to understand that being a bone marrow donor isn't necessarily what they think. The fact is that there's a lot of misconception out there about what it really involves, and a lot of that comes from from Hollywood over dramatizing the process on on TV shows and in the movies, making it sound very, very scary and very painful, when in reality it's far from the truth. We have donors come into our offices at Gift of Life every day. 3 of them came here today to donate their stem cells. And I can just share very quickly the experience. They donate blood from their arm that goes through a machine that separates out the stem cells. While they're doing it, they watch Netflix. They get to enjoy time with their companion who's with them from home or work. They enjoy some lunch and some fresh baked chocolate chip cookies. And after a couple of hours, they're finished. They get to go home. knowing that they just saved a life. I mean, what greater gift can one human being give to another, and particularly doing something so easy? You know, when it comes to being a hero, we don't all have to wear a cape. Heroes are ordinary people.
There you go. Okay, thanks a lot. Hey, one more question before we get ready to wrap this up. And this is for Dr. Shepard. There's a question. Is there a resource to go to if you need help? If someone needs help out there, where should they go?
Yeah, there are so many different resources that are out there. I would say National Alliance of Mental Illness, NAMI, is one of the most prominent organizations that's out there that literally has local chapters throughout the country. You can also check into the American Psychiatric Association, which I'm proud to be a part of. The American Academy of Child and Psychiatry. You can also check there. Their websites are out there. There are also national suicide hotlines. And hopefully, I'm hearing that in a couple of years, we were actually going to have a national suicide hotline where 988, I'm hearing, is going to be approved through Congress. I'm hearing that it's making its way through. And so hopefully that's, probably the next president will have to sign that into law. And so I'm just hoping that this does happen. So there's different local chapters of these different organizations that I mentioned. I must mention, I'm the president of the board of directors of Black Mental Health Alliance. And so we are serving people actually throughout this whole country. And so you can give us a call and we may be able to help you also.
Okay, well, this is outstanding, an outstanding panel here today. We went through a lot. There's a lot to unpack, and we just didn't have time to unpack it all, but we really appreciate you, Dr. Carr, Dr. Rivers, of course, Dr. Shepard, Amari, and Jay. This was an outstanding panel, outstanding discussion. The last thing that we want to do to make sure that everybody understands is those who are watching us right now, especially if you are that college student, you got to get out there. And Amari pointed to this. You got to get out there and vote. You must vote. Your voice must be heard. We could talk about it on social media. We could talk about it in these chat rooms. But if we don't take decisive action and vote, then you will not bring about change. So once again, thanks everyone for joining us today. And we really appreciate it. And we pray that you have a blessed rest of your evening.